we will talk about applies to any patient, Medicare, A, or Medicaid. You have the right to choose any hospice that you wish.
Okay.
Full disclosure. There are many hospices and palliative care programs, probably as many as there are coffee shops.
Really?
Yes, there's a lot. I represent Altman Hospice, but the things that we talk about apply probably to anybody.
Is that the one on Woodlawn?
So Woodlawn has an inpatient hospice unit.
Okay.
Hospice is not a place. So hospice is a group of people that go to patients wherever they need to be. A
Okay.
lot of times patients go home, which his home is his nursing home where he lives. In that instance, a hospice pays for all the equipment that patients need to be cared for safely. So hospital bed, bedside commode, overside table, oxygen, all the equipment and the medications that they need to be comfortable, and the nursing care, all that is covered at 100%. He also has Medicaid, which would pay for room and board, as it always has. So that's not at all a problem. So you don't have to worry about anything being out of pocket for him. In order to go to Woodlawn, our compassionate care center, that is designed to care for patients who can only be safely cared for at a hospital setting. So usually patients that have a lot of uncontrolled symptoms that have to have IV medicine for nausea or pain or constipation. So luckily he doesn't fall into that category. He's very asymptomatic, which is wonderful. It also means that he can go back to a place that you want him to go to. If you think that his nursing home took good care of him and he knows the people there, then maybe it makes a lot of sense for him to go there. Otherwise, he doesn't qualify to go to the inpatient level of care at this time because of his lack of symptoms.
Okay.
If you wanted him to go to a different place, you certainly could arrange that as well.
Yeah, my mother was at the Altman one, so I'm very pleased with that one. That if we needed one, that's probably where I would want to take him.
Sure.
But he can't go there.
He does not qualify to go to the Woodlawn one at this time because he doesn't have symptoms that mean him to need a hospital level of care. That's really only meant for patients that need to be at a hospital.
So then how do they control like his pain? Like
all of the medications that we give for pain, for nausea and things like that can be swallowed in a pill form or they dissolve on the tongue. And he doesn't really have a lot of those things going on right now anyway. But we would still be able to manage those things very safely in a nursing home or a home setting.
So at the nursing home, how long is the hospice person there? Are they there?
They're in addition to all the other nursing care that he gets. Usually when we talk about a home or a nursing home type setting, you can have an aide or a nurse that goes out, usually 3 hours of nursing services a week and then 5 hours of aide services a week, and they alternate so that somebody gets to see him. If he becomes more symptomatic and we're changing medication, sometimes we have a nurse go out twice in the same day even, just to make sure that those medications work well. But if he remains asymptomatic, they may not be doing more than once daily visits or once every other day visits.
What is asymptomatic? I mean, what?
If he's not having a lot of pain or nausea or shortness of breath and he's not requiring a lot of medicines, they may not have to check on him as frequently.
So they don't feel that he's at that point right now then?
No, I don't feel that he's at that point right now. He's not requiring a lot of medicine at all for any symptoms. No pain,
because
no
they were
nausea.
giving him a whole bunch of stuff back at the nursing home. Now, who will determine his meds?
That would be the hospice agency. They determine his meds. So he would certainly get anything to make sure that he's comfortable. Pain, fever, constipation, nausea. We'd also have to look at antibiotics. So right now he is on IV meropenem. We cannot give meropenem by mouth, so we'd have to get a different kind of antibiotic by mouth. And then we also stop medications that don't make sense anymore. Cholesterol medicine is the biggest one that doesn't make a lot of sense because you need to take that for 10 years for it to give you additional survival benefit, and we're past that for him. So we would decrease a lot of the medicines that just don't make sense anymore.
He's on a lot of psych meds too, isn't he?
Yeah.
That's
Psych meds would stay. Anything that's necessary for his quality of life.
Is he still on them now in the hospital? Is he still giving me psych meds, you think?
As far as I know, yes, he's been resumed on all of his home
Because
stuff.
he's much more alert than he was back at the nursing home.
This is the most alert I've ever seen him in the
Which
last
is
year.
Yeah, we were wondering if maybe they took him off of that stuff.
Initially, when he was in the ICU, they probably did not resume a lot of his meds while he was not very wakeful, while he was in shock.
Mhm.
But they have resumed a lot of his home meds now, just because he's in a safe space to do that. He's awake, he can swallow things, so it's not dangerous to have him on those. A lot of those medications too, one of the side effects is dropping the blood pressure. So when someone's in shock, they're not necessarily safe to give. But anything that's important for his quality of life, like his psych meds, would be resumed.
Okay.
So is he considered improved from when he first got here?
I would say he's no longer in septic shock.
And that was the biggest issue?
That was the biggest issue from an infection standpoint,
Okay.
yes. So the infection is kind of being maintained right now with the antibiotic that he's receiving, and he can have a pill form of an antibiotic when he leaves.
Mhm.
It won't be as strong as meropenem. So that's why when we talked yesterday about not doing the chole tube for a drain for his gallbladder, we may see things kind of worsen rapidly from an infection standpoint too, if that's really where the infection is. But the big picture is he's still eligible for hospice from a cancer standpoint. So he may have good quality life if we keep the infection at bay with antibiotics and he doesn't decrease. We could be looking at that weeks to months picture instead of the days to weeks picture from the infection. But still would be eligible for hospice from a cancer standpoint.
From the cancer. Okay.
So he could go to hospice now based on the cancer?
Irregardless of the infection, yes.
But hospice is not a place, it's a person.
Right, so
Like,
he
is
can't-
Crossroads a hospice?
Crossroads is a hospice.
Because they mentioned Crossroads, somebody mentioned Crossroads coming in, who was that? Remember we talked to somebody,
Yeah,
and they
somebody
mentioned, maybe
mentioned that.
was it Dr. Marsh maybe, or somebody,
Is he not eligible for any in-house facility, like to go there and stay at this?
Sure. So he can go to a nursing home and get hospice at a nursing home.
okay.
He does not qualify for a hospice hospital. So there's other ones. There's the Compassionate Care Center here. There's also like the Truman House at New Philly, which is run by Ohio's Hospice.
Mhm.
Crossroads, to my understanding, does not have an inpatient unit or a hospice house, typical hospice house that people
That's what I
consider.
understood.
Okay.
Yeah. So again, in order for him to go to a place like that, usually those hospice houses are limited because they're not technically long-term care facilities, so they don't let people stay there beyond a few days to weeks. So certainly if someone has a shorter life expectancy, we can talk about them going there and paying out of pocket potentially for room and board to go there, because usually hospice houses don't accept Medicaid as a payer source because they're not a long-term care facility like his nursing home where he lives now. But because we think that his infection is much better, we're looking at that weeks to months picture. It wouldn't probably be approved for him to go to a hospice house to live long-term
Okay,
because they're really designed for short-term.
for short term.
So he probably can't stay here in the hospital, right?
Correct. We do have
So-
to look at a discharge plan.
Right, so then he would go back to the nursing home. That's the only other place that he can go.
Yes.
I
at
mean,
this
why
point.
change nursing homes? That doesn't make sense.
Well, and I
Yeah.
wanted to bring that up. It sounds like he's happy there and you're happy
Yes.
there.
Yeah.
But if you weren't, this would be the time that we would talk about going to a different place.
No, that would,
I'm happy there, but I'm not sure that any other place it's going to be
Any different.
any different. I mean, the care he gets here obviously
Mhm.
surpasses what he's going to get at the nursing home.
Yeah.
But I think that the staff love him. He's been there 12 years.
I can imagine that they would. He's such a sweetheart.
And so I think, I don't know, I think, what do you think? Going back to the same place for his
obviously.
peace of mind?
I mean, probably. I look at him and like, he was in some pain today. Like at one point he's like, oh my God, my back. And then he's had the bowel issues because he's got that tube
Mm-hmm.
in the rectum.
Mm-hmm.
He just had an accident with the catheter. Like, I just wonder, are the people there going to, like, do they care for him? Like, he's got to sit there if he has an accident for an hour or two? Or are they, you know what I'm saying?
Mhm.
Like, that's the scary thing I feel like about
Well,
nursing
yes,
homes.
yes.
You know, it's
Yeah.
just like,
That's probably where I'm coming from too.
Yeah. unfortunately, he doesn't meet the hospital criteria.
So when you think eventually he would meet that?
I don't know. Most patients, and it's a very small portion, end up needing to be at the inpatient unit under the hospital level of care at end of life. We're talking less than 3% of all patients that are in hospice. 96% plus die in a home-like setting, and they're very easy to manage with medications that dissolve under the tongue or to swallow pills. So I don't know that he would ever need a hospital level of care.
So how did Grandma get in there?
Well, she came into the emergency room. She had fallen and hit her head.
Mhm.
She was 96.
Yeah, so she
In the-
probably had a brain bleed, and
That,
yeah.
that could.
So that we would be looking at a very short period of time then too.
She was only there, what, like a day or
Couple
A
days.
two?
day or a day and a half.
It was very nice.
Yes.
But
Yes,
I see
yes.
what you're saying.
Mhm.
I just hope, I do think that he is comfortable there. It's his home.
Yes.
I just look at, okay, I'm not arrogant, but I look at some of the people working there and I'm just like,
You worry and you want to make sure that he gets the best care possible. That's not at all an arrogance.
why are they working there and not here? Are they not skilled? Or are they at the bottom of their class? Like,
Oh,
Well-
I don't know. We need people to care for people everywhere in medical field. So if it's in a hospital, in an ICU, on a regular floor, in a nursing home, we need nurses everywhere.
so the ones at the nursing home, it's not like they can't get a job here. They're choosing to work there.
So what happens if he gets to the nursing home, after a couple of days, his infection starts getting worse and worse? Do they take him back to the hospital then?
If we talk about hospice, our goal is not to return to the hospital when someone is at end of life. So if his infection were to get worse and he were to go into shock again, he would be actively dying. And we would hopefully be able to keep him where he enjoys at home, manage his symptoms there at end of life without moving him back to the hospital. That would be not the goal, because coming back to the hospital would be prolonging life artificially with IV
Right.
fluids and antibiotics. And
What determines how many hours a week he would get hospice care?
so there's always someone available 24/7, but how often they would come and see him is based off of how frequently we're having to change medications and what his needs look like in that regard.
What did you say? Like 3 hours?
Typically, it's 3 hours of nursing care and then 5 hours of aid service a week, typically. But if someone is needing medications changed frequently and their symptoms are starting to flare up and we need to change pain medicine and things like that, they're seen more often.
So that he would typically be seen, an hour a day for 3
Yes.
days, or
Mhm. And that's in addition to his nursing care.
And
It's
it-
not that it's separate.
yes.
Mhm.
Okay. And if you wanted to increase that to say every day,
Mhm.
financially you can pay for that?
That I would have to check into. It's
Okay.
usually based off of need. You can hire additional nursing service on top of what he's getting in the facility and on top of hospice if he wanted to be seen more often. If he's not having a lot of symptoms, I don't know that we could see him more than that just because of the nature of
So
hospice.
you can't pay to have more hospice, but you could pay to have additional
You could pay to have additional services through an
Services.
agency for sure.
through an agency. Okay.
Yes.
So do you think the nurses that, like, so say he develops pain or, do you guys think that they take care of him there, or they just kind of like,
No, generally they call the doctor and the
Yeah,
doctor usually
I think
prescribes
they do.
something.
I mean,
They've got a new doctor though, I don't know her name.
obviously some are more attentive than others, but they have one nurse sometimes for,
I know, like that
Yeah,
to
a
me
lot
is
of people.
crazy. Like, what if you start suffering or something and there's like one nurse there?
well, that's just something,
What do you see happening? Do you see the infections being stable for quite a while? Do
It's
you
hard
see it?
to know. I think if
Hard to know.
he looks really good right now from an infection standpoint, everything is trending in the right direction. He's a lot more awake, like you said, even from yesterday to today. I see him being a little more spunky. His labs all look better from an infection standpoint. I foresee that if he continues to tolerate antibiotics by mouth, he may be able to stabilize, and we'd be looking at more of that weeks to months picture as opposed to those few days. Looking at him now, that would be my best guess.
In weeks to months due to the cancer or to the infection?
Yes, weeks to months due to the cancer. Mm-hmm.
So they would assess him like as the cancer progresses, will it get painful or not necessarily?
I don't think so. His is in the tail of the pancreas.
Oh yes, we talked about that.
So I don't think that it's going to push on anything important. But regardless of why people progress to death, if it's from a heart or a kidney or a lung or a liver issue, pain is something that can sometimes happen. It may not be from the cancer directly, but it could be because he's weaker and he's uncomfortable being in the bed more, things like that. So those are things we very commonly address in all patients. There may be some amount of pain or nausea or shortness of breath in all patients.
Do you picture him, if we go back to the nursing home, being in bed like he is now, 24/7?
I would imagine, because he wouldn't be getting aggressive physical therapy to get him up and things like that. So it would be largely determined on how much he wants to get up to chair.
If he wanted to get in a wheelchair, do you think that's feasible for him at this?
I think so. He's able to participate in some amount, certainly awake enough that it would be safe for him to do that.
Yes.
We have a lot of our patients on hospice who get up to chair or get up to wheelchair with a lot of assistance. But again, it wouldn't be with aggressive physical therapy. There's not going to be a physical therapist that comes in to do
Well,
those
they
things.
have been putting him in and out of bed with a Hoyer. And I'm assuming that's the same way they put
Yes.
him in his wheelchair.
That would probably be the same. He's not going to get any stronger. He will only get weaker. So they would probably still have to do the Hoyer.
Okay.
And as long as he's awake and interactive like he is now, that would make sense. I would be hesitant to use a Hoyer to put him up in a chair if he's very sleepy, because then he could fall, and that would be a dangerous thing. So when we get to that point where we have progressed through the dying process and he's more sleepy, it would no longer be safe to get him up the chair with the Hoyer, because you wouldn't want to put him in a dangerous situation.
Do you think where he is now, he's capable of being put into a wheelchair to...
Looking at him today, I think that would be reasonable
Okay.
for his quality of life.
Yes.
How do we control the diarrhea problem he's having and that type of thing?
Yeah, there are lots of medicines that we can use to help with diarrhea, and it has slowed down quite a bit.
Really? Okay.
Yes. Unfortunately, one of the side effects of using antibiotics for patients is sometimes diarrhea, because we mess up all the bugs that normally live inside your guts.
I thought it was just the opposite.
He usually has the opposite problem. This is like...
But then the nurse down here said that they gave him something for constipation, which is what's causing the diarrhea. I was kind of shocked that she did not know half
Oh, that's
of
true.
what was going on. Like, we had to explain to her. That's crazy too, that it's not all like in a computer or something. Or was she supposed to go look at that?
I don't know. We had to fill her in on, I don't think she had any idea.
She did not know about the gallbladder issue. Like, it's just that kind of stuff. I'm just like, how can this be in the medical world? Like, he was moved down the floor and this nurse has no idea. Like, that his gallbladder is inflamed and...
Is that typical?
I think when they have so many patients, they may not know
They have a
all the
lot,
same
yeah.
details. And I'm sure she was hesitant to say the wrong thing if she didn't know for sure.
Well, yeah, I could
Yeah,
tell.
sure.
So I'm like,
Yeah.
hey, can we have a conversation in the hallway? And I didn't mind. Like, I'm like a outgoing, like
Yeah.
proactive person. But that just, you would just think that it would all be like right there.
Well, maybe
like,
she just came on duty too and hadn't had a chance to look at the records too. I mean,
yeah, I don't know.
it's not
I
like
guess that's my thing with the nursing home. It's just like, is he gonna sit in poopy pants for like 2 hours? Like,
well, that shouldn't change because he's been there.
Yeah.
He's been doing
he's
that.
had bowel issues there.
True, right, and urine issues too. So
And if you felt that the care he received there was good, you're going to only have more help with hospice.
That's true.
Well,
That's a good
so-
point, yeah.
And they would be probably checking in
I just don't
That-
want
yeah.
you to feel like for weeks you have to go sit there every day because all day long. I just don't think that that's
Healthy.
healthy.
Yeah.
Because eventually I have to go back.
Yes.
Right.
Like I'm a stay-at-home mom and my kids are older, so I don't have to be there.
Right.
Well, I have to be there right
Yeah.
next Thursday to go to Chicago for volleyball.
Yeah.
But like that makes me nervous too. It's like if, I don't want you to feel like you have to go there because you're not trusting their care.
No, I don't think.
Did you feel like you had to do that before?
No. I mean, we took supper every Sunday night, or every other Sunday we'd take supper into them and everything, but we
Yeah.
weren't over there checking up on them every day,
No.
you know? They would call
I know,
us if they
I
had an
would-
issue.
Like to get in and clean his room.
Yeah.
His room has never been. They don't do proactive cleaning.
Mm.
Yeah.
He has a shelf with stuffs and it's full of dust.
They don't do a good job cleaning, but
Yeah.
But why? Like I don't understand these places.
yeah.
I don't know. We
know.
just need to get some of
Yeah.
the stuff out there, simplify it, the room. But I don't know. I've never seen them really. They do the floor, but like dusting and stuff, I've never seen them actively.
And they do like him.
Yeah,
Right,
they do.
yeah.
He's never complained about anybody.
And that's the big thing. He knows everybody there,
Right.
and he
Right.
knows the nurses.
Yeah.
Mhm.
And he's never complained about poor care that he's received,
No.
right?
No.
No,
No, it never has.
We have to deal with the Shirley thing. He has a girlfriend.
Oh.
And
she
she
thinks
is.
Oh,
She's
God.
been calling me.
She's like about the same level as he is,
Yes.
like lower IQ, you know.
Does he reciprocate? Is he also in an agreement that she's his girlfriend?
I think he likes her, but
She's in love.
she's in love. But
It's
he's,
friendship.
He's never had
I
a
understand.
girlfriend, so.
I mean, my mom is her sister-in-law, and she, you know, she's no family. But I think it's like she can't be in there taking stuff out of
Yeah.
his room all the time, especially that new dinosaur that I got him. I tell her to keep her hand.
Yeah, she. I hate to say a pest, you know. But,
Yeah.
But she is. They finally had to tell her you can't be down there 24/7, and Dave didn't like it sometimes. He wanted
Sure.
to take a nap,
But it gave him somebody to hang around
but
with.
it does give
They
him
color
somebody-
together. They do, you know.
He's so nice. I would find it very difficult for him to
Yeah.
say no.
Let me ask another question. As far as a caregiver goes, okay? She got up this morning and she was not feeling well. She was shaky and everything. What do caregivers go through?
Sure.
I mean, is this a normal reaction that?
I think it's very normal. So what you're dealing with is anticipatory grief. So even though David's still with us right now,
Yes.
you're thinking about him dying and what life will be like without him, and you worry about him because
Yeah.
you want to protect him and keep him safe. It's often that caregivers do not eat or drink water like they're supposed to.
Yeah.
And because you're so wrapped up in all these big important decisions and making sure that he's cared for safely, you may not remember to take your medication like you're supposed to. So there's all those things.
I think I just. It hit me, and I was tired,
Yeah, this is a lot.
and yeah.
It's very physically
It is.
taxing. It's
It is.
emotionally taxing.
And last night, when I went to bed, I was upset all the way home. And so we were up a while, and I went to bed, and I got the shakes, and I couldn't quit shaking. So I finally got up, took 2 Tylenol. That helped a little bit. Then I was cold, so I got the heating pad out and laid
Yeah.
down on the heating pad. And then I fell asleep. So
But
It
I don't
is.
want to go home and worry. Like, she's AFib and it's treated. Like, she
Yeah.
had it a couple of
Yeah.
stress brings it on.
Yeah.
She's on Eliquis, but like, I don't want you to stroke out over this, which is why I don't think you can
Yeah.
go sit there
no, I don't
in
think I
that
would.
nursing home for like
Yeah.
12 hours.
And, and you don't have to. Because
Yeah.
what hospice does is it wraps these support services around.
Yeah.
So they'll be there too. And even if they're not in there at the moment, if something happens, they have a 24/7 number to call us directly so that we can make changes and make sure he has what he needs regardless of what it is. And we have chaplains and we have social workers and we have music therapy. And there's also bereavement support for after David's gone. You get a year's worth of free bereavement. So there's all those additional things to make sure that he is safe and cared for. And the benefit of him going to a place that knows him and loves him and that has been that for a long time with hospice
Yes.
is that you don't have to do all the caregiving 24/7, and you
Yeah.
can be his sister
Yeah.
and let you actually be present for the time that we have and
Yeah.
actually be here and do the things that you need to do
Yeah.
to process your grief, as opposed to giving him his medicine and bathing him
Yeah.
and all those things
True.
that you would do otherwise.
Yeah.
You're welcome to do as much as you want with
Mhm.
him physically too, but it's not what you have to do because there's other people to do that.
Yeah.
And he'll have other people there to
Right.
probably talk to.
Right.
Mm-hmm.
That because he definitely recognizes people.
Mhm.
And
Yes.
Yes.
Okay.
I know we were thinking he would go to some place like Grandma was.
Yes.
Yes.
Like Woodlawn.
Yes.
But then we did talk about like the nursing home. He does know people there, and if
Yeah.
you think the care is, I just don't want him to lay there and suffer because it's crappy care.
Yeah.
Mhm.
But you're saying it's like that's what I don't know.
I know the nurses on duty like him.
Right.
You know, the guy, Mark,
Mark, like, you know.
and the.
And they usually call if something happens, or
Yeah.
something. They always call you
Yeah,
and
they-
say, "Well,
they
we
do.
are
They
we."
call.
They even call if they change medication sometimes,
Yeah.
don't they? Say we've changed his medication,
So,
so
is
they
it
do.
appropriate to have a meeting with them?
Oh,
Yeah,
I think so.
If
yeah.
you're considering him going back to that place, you can call them and see. And
Yeah,
Like I would have like these are my expectations. Like if he
Mm-hmm.
comes,
we'll do that before you go back. She's
Okay.
so good at,
Yeah.
at focusing.
yeah.
I'm a little at this point, a little here and there.
Mhm.
She's very good at focusing.
And you have every right to be here and there.
Yeah.
Mhm.
You have every right to be here and there. And that's why it's important for us to talk today, just so that you know too
Yes.
what's possible under the hospice
Right.
insurance benefit
Right.
at the moment, just so that you can kind of plan what makes the most sense.
Do you have any idea how long he'll be here before he would go back there?
That entirely depends. So, if you made a decision that you were ready for hospice and things like that, usually we can get equipment and things in there within 24 hours. If we're obviously not deciding yet, he has to be medically stable to think about discharging from the hospital, even if we don't choose hospice right at the
Mhm.
time of discharge.
Mhm.
So, if that is a separate issue altogether. He just got out of the ICU. So, if you guys said, hypothetically, we're not ready for hospice yet, we would still like to bring him back and forth to the hospital and things like that. He has to be medically stable to consider discharge back to his facility. So he has to be, they have to figure out an oral antibiotic regimen. They have to monitor him outside of the ICU. Right now he's in a step down. So we're still a few days out of that even.
Okay, so
So-
we're talking a few days here
Yes.
that we have time to make
Mhm.
a decision.
Yes, you don't have to make one
Now,
right now.
and let me clarify, if he goes hospice, then he
Mhm.
can't return to the hospital?
Yes, so the plan if someone goes on hospice is that we manage their symptoms where they are, we keep them out of the hospital because your desire is not for him to die in this hospital, right? You want him to
Mhm.
be where he's loved and cared for.
Mhm.
If he got to a place where his symptoms could not be safely managed at his nursing facility, that's what the inpatient hospice unit is for. So if your goals are still symptom management at end of life, and he were to develop, pain that we couldn't safely manage, and we needed to get him in and get him IV pain medicine, instead of coming to a traditional hospital, he goes to a hospice hospital.
Like Woodlawn.
We're still
Yeah.
focusing on symptoms at end of life without doing things that prolong life artificially. If you change your mind and you don't think hospice is appropriate and he gets sicker and you want him to come back to the hospital for IV fluids, IV antibiotics, you would just revoke hospice and then you could do those things.
Okay.
Mhm.
what do most people do, or is it like 50-50?
Yeah, I would say most people, if you make the decision that you are ready for hospice at end of life, most people don't revoke, and then when death is happening, death happens naturally as it is
Right.
intended.
Like I would want to know, has this nursing home? I'm sure they've had to deal with this
Yeah.
before,
There's lots of
right?
nursing
Like they've
homes
got
that-
experience
Yeah.
in this.
Mhm. There's a lot of nursing homes. There's been quite a shift. So it used to be back in the 60s when hospice was first created as an insurance benefit. Most people wanted to die at home, and they were able to die at home because it was a single income household. So the wife could take care of the husband in the home.
Yeah.
But now people have to work to maintain insurance.
Mm-hmm.
And because both people are working and a lot of the kids are working,
Mm-hmm.
they can't be 24/7 caregivers in a home setting. So there is a big shift that people are in nursing homes and end of life where their families get to visit them, but nursing is caring for them because they have to work outside the home.
Who determines his medication? The
Hospice.
doctor or
Yes,
hospice?
hospice.
So the
Mhm.
doctor in the hospital, what is her role then? The doctor or who oversees the hospital? Does she have a role?
I'm so sorry, I'm confused.
I'm confused too.
All right, there's a doctor that is in the hospital. Not, did I say hospital? Nursing
Oh,
home.
in the nursing
There's
home,
a
yes.
doctor in the nursing home, the new doctor, whoever.
Yes.
And
That
now what is-
doctor will still round on the patients. They usually, at a nursing home, I forget what the requirements are, but unless someone is needing to be seen very frequently, I think it's once every 13 days or something like that. So they don't see patients all the time.
Right, she comes in once every
Yeah.
couple weeks, I
I thought
think.
she said, I don't know.
And then they have a nurse practitioner there
Mhm.
also that comes
Yes.
in every 3 days, I think.
Yes, so they're still able to see him and monitor him, and they can certainly make changes if they think they need to.
Mhm.
You have the right to choose who is the physician of record for your loved one when they go on hospice. Most people choose the hospice doctors that work at the hospice agency that you pick. You can still pick their primary care provider if the primary care provider feels comfortable managing people at end of life with
So
those
there's a
things.
hospice doctor that will be assigned to him then?
Yes. So, for example, for us, there's 3. There's myself, Dr. Marsh, and Dr. Cast, and whoever is on at the time that there's a question manages him.
So you could be responsible for him?
I could be, yep.
Oh, I see
Like
that.
that.
I would certainly
And-
be initially responsible for him because I'd go through all of his medications and
Yes.
determine what makes sense and what antibiotic would be the best
Now,
choice.
does like yourself, the hospice or the doctors in charge of the hospice or in charge of David, do you typically meet with the people in the nursing home and lay out what is going on?
Sure.
Or do you just send them the report and say,
We work very closely with them. It's mostly nurse driven because they're the ones going in
Right.
to see the patients.
so you would have a meeting with them?
They're
and say
they're aware
these-
of the hospice plan of care.
Okay,
yes.
so these are Dave's problems, these are his
Mhm.
requirements,
Mhm.
and this is what you need to do, right?
Mhm.
All right, that makes me feel better.
Yeah, and
Yes.
that is true of all hospices. There's a very
Okay.
clear hospice plan of care that addresses medications and nutrition and wound care and all sorts of things. All
Okay.
those things are
Oh, I
addressed.
didn't realize
It's a
that.
very extensive plan of care.
So who was the third doctor? Is Dr.
Dr. Cast, Kast,
Okay. Male or female?
male.
How do you choose one? Just flip a coin, or
Huh?
how do you choose one? Just flip a coin, or
As far as who's in,
Who's
it's
the doctor?
it's who's on duty.
It's who's on
Yeah,
duty.
It's who's on duty.
oh, who's on duty? Okay.
Yes.
So you would technically all 3
Yes.
could be treating Dave.
Yes.
I see.
Okay.
Okay.
That makes me feel better.
Yeah, it does.
When you have a face with somebody that, you
Yeah.
know what I mean?
Yeah.
Because I don't even know what the doctor at the nursing home looks like. You know, they've gone through a couple of them, I guess, and
They go
And
staff switches.
and they
a
will
lot.
still, the nurse practitioner or that doctor still typically do what they normally do as far as rounding. And if his blood pressure is a little low, they may say, oh, we're stopping this blood pressure medicine or we're decreasing this blood pressure medicine, but we all communicate with each other about what makes sense. They certainly rely on the hospice docs a lot, especially for symptom management, and they will be able to reach out to us 24/7, even if it's something like 2 a.m. he has more pain, we need to adjust pain medicine. That's something that we'd be able to do on top of the typical nurse visits.
I mean, he probably would be more happy in his own
oh,
place.
definitely, yeah, yeah.
I'd like to ask him what he thinks about Shirley.
About Shirley, what?
I don't know I know he told me once, and he's always in her room. They go down, they work puzzles, they color, they have a TV now, and they are always wanting to order DVDs, and she's figured out how to do that. I think, like I said, I think he's always sometimes indicated that he just wants to go take a nap, and then she comes down. So they're very good at limiting that.
Good.
And I told her when he was still there, I said, Shirley, maybe go twice a day. And she said she's been doing that. But, every time I've seen her go in and she's scurrying down the hall in her wheelchair. Really? You're not supposed to be in there.
It sounds complex because you want him to have joy and happiness and
Exactly.
socialize,
Yes.
but also place limits so that he has his peace.
He
And you
needs
don't want to have his peace interrupted.
He needs his space. She would be with him 24/7 if she could. I mean, I think she wants to get married, but he said no.
Now is not the time, Shirley.
And we're all saying no.
How sweet. So I think at this point, what makes a lot of sense for your comfort, if you wanted to reach out to his nursing home and talk with them,
Okay.
and certainly they may even have a recommendation about what hospice agency, but you do have the right to choose anybody that you want. Do your research. I know that you guys are very intellectual. Do your research and find what you think is best. But everything that we just talked about is
So you
pretty
are-
standard.
You are Altman Hospice.
Yes, ma'am.
And you work with different hospice agencies, right?
We represent Altman Hospice. We can go any place within our service area.
So why would we want to go someplace else? Why not just stay with the Altman Hospice?
I'm flattered. I would like you to stay with Altman
But
Hospice.
she has to say
But I
that.
always let you know your rights.
Yeah, right.
I let you know your rights.
Right.
Okay.
You probably can't say, but have you worked with this nursing home before?
I do believe we have a contract there, yes. And
Okay.
I haven't heard any big concerns.
It's now the
Okay.
Pavilion at
In
Edgefield.
Pavilion at
Right, yeah.
Edgewood, yeah. Mhm.
We talked the other night, you mentioned about this, the diagnosis of the prostate cancer.
Of the
Prostate.
pancreatic cancer, yes.
Pancreatic
That's
cancer,
all
right.
right.
But, you know, and they've just seen different things and it's consistent with,
Mhm.
all right, she asked, could it be something else?
No.
That's a pretty quick answer.
I'm a doubter. I'm
She's a
sorry.
doubter.
I don't know anything else. And the only way to prove it to you
Is
would be to do a
biopsy.
biopsy.
Right.
And we could do a CT guided biopsy of the liver, but he'll wonder why. And if he doesn't want to know,
Yeah,
it's kind of hard to
Okay.
pretend that we're doing anything else, if that makes sense.
yeah.
It's something that would be a very simple thing. He'd tolerate it well, but he'd wonder why.
Yeah.
Yeah. But that's the only definitive way to tell you for sure, without a shred of a doubt that it's pancreatic cancer for your own peace of mind. If
Could-
it's important, we could.
Have there ever been other growths that people have inside them that are not?
There are plenty of things that are not cancerous, that are benign, that grow inside the body. They do not look like this. This is pancreatic cancer that has gone to the liver.
Okay.
I can tell you that definitively without a biopsy.
Okay. All right.
Hang on.
Shirley.
It's Florida.
Oh, I thought
No,
you were saying it was
her
Shirley.
No, it wasn't.
She called
this time.
earlier. Her brother.
Oh, John, understood.
No, it wasn't. I don't
Oh.
think.
Hmm.
I don't think that's his
No.
number.
All right, so the plan then is to
Talk with Pavilion at Edgewood.
Pavilion at Edgewood and we're
Reassure
gonna,
yourself of any concerns
and we're
and
gonna add, the questions we ask them are,
whatever you'd like. You had some concerns about how well he'd be cared for and things like
Yeah.
that. So I want you to ask them those
I
questions.
would put like just kind of make it like these are kind of our expectations. Like
we should
Yeah,
get
you
with
know.
the administrator. She's a nice lady.
She
Yeah.
is.
She's
I would
super.
say the
She's a new
administrator
lady.
or the director of nursing, the DON.
Well,
would
we'll
be the
talk
two
to
people.
Janeri, she's the director of nursing,
Mhm.
and maybe get the other girl.
and Janeri's been there a while.
Yeah.
right?
Janeri's been there a while, but the director of nursing is new, but
They always have a new one, don't they?
Exact-
not
the administrator.
admin. But
Mhm.
we were standing there
Yeah,
and
she's super.
at the main desk and we were talking and somehow she said that's who she was and she said, oh, here's my phone number, call me
Yeah.
if you need
Couldn't
anything.
believe it.
Oh, that's nice. That's
So
great.
I
She's
think
a
we'll
principal.
call her.
I
Yes.
think before, she's only gonna be there for a couple of weeks, I guess, or until they
Well,
find
she's
an
an
administrator.
interim till
Yeah.
they find somebody
Sure.
else, but interim.
So we should call her, set an appointment with her and Janeri, and maybe
Yeah.
the assistant director, the girl we talked to, Tisha, whatever her name was.
Keisha, yeah.
She was pretty
Keisha
good
was
too.
very
She
good.
knew more than Janeri did, actually.
So
Okay.
switching the topic a little bit, what do we tell Dave when we go back?
That we're going back home.
Mhm,
And
that's
we're
what I
going
was
to make
gonna
sure
say.
that he's comfortable.
Okay.
That's what I would leave it at that.
Okay.
And because he doesn't want to know what's going on,
Yes.
I'll make sure that we don't say hospice because he doesn't want to know and he won't necessarily understand all those things. Again, that's that benevolent deception piece.
benevolent deception. Like
Yes.
that.
Yeah, like, hey, you're going home.
Yeah,
You're
right.
going home.
You got the
We're
infection.
gonna make sure that you're comfortable.
Yeah.
They just say they think you're ready to go home in
Yeah.
a day or two, and
Yeah.
Okay.
And then
All right.
I'll circle back sometime tomorrow afternoon, unless you call
Okay.
me, and we can go from there,
Okay.
based off of whatever you decide.
Oh, did you get her card? I know that she gave a card.
did you give me a card yesterday?
If I'll grab another one, that's all right. And then two, gosh, if you lose my card, because they are kind of small, on both of these handouts, there's the number for our offices
For your
too.
office,
Yes.
okay.
So
Okay.
let me grab a card then.
Okay.
And I'll make sure to drop you back off, so I don't
Okay.
get lost.
Do we know
Wandering
where we're
around.
going?
Yes, yes, I'll take you back out. I'm gonna pop over to my office real quick,
Okay.
and I'll
Okay.
grab you.
Okay.
I think,
Seems like the best.
yeah, at first I was like, oh shit. And then I think,
I'm very surprised.
Huh?
I'm surprised at you.
I know, at first I was like,
I thought we would not be doing this.
are you okay with it?
No, I said I thought we would not be taking
I know, because I thought that's kind of what they said yesterday.
I didn't know yesterday. But that's,
Dave, but I would definitely not go. I would
Yeah.
just be like, these are our expectations.
well,
it. Yeah.
Like, not in a bad
I
way, but
know.
I would just say like, these are kind of,
Are you
you know,
going to be able
be
to
able to
do
do
this
this
and
Are you
this
gonna
and
be able
this?
yes, like, we, you know, we don't want to be, I would just say like, I can't be here 12 hours a day.
Yeah.
But we want to make sure, like, if he has an accident, that
Yeah.
he's not going to be sitting in that and getting like skin infection. I mean, because that can happen. But he's had accidents before.
but you know, like she said, he could live another 2 months.
Logan better not take my dinosaur.